Bismillah ar-Rahman ar-Rahim. Our lecture today, colorectal cancer. Void of the tinea coli with complete sheath. The medial 2/3 of the transverse colon. And this is the inferior mesenteric artery. It is arise from the aorta at the level of the third lumbar vertebra. It gives the left colic arteries, 1, 2, 3, and then the sigmoid branches, and continue as superior rectal artery. So the inferior mesenteric artery gives 4 sigmoid arteries and gives the left colic artery, which anastomose with the middle colic artery. Here, this purple one is called the artery of the Daramond. This artery of the Daramond is responsible for the interanastomose in between the superior and the inferior mesenteric artery. And we have to preserve this artery during our dissection because this is the main, which supply the collaterals in between both branches, both of the superior and the inferior mesenteric artery. There is a weak point which is a splenic flexure. Here, in between the superior and the inferior mesenteric artery, this is in between it, the middle colic artery with the left colic artery. This arises from the superior middle colic from the superior mesenteric and the left colic from the inferior mesenteric. So this is the anastomose in between the right middle and inferior and the superior mesenteric arteries. Colorectal cancer or colorectal polyp or personal history of inflammatory bowel disease or family history. And what are the inherited disease? Inherited diseases which predispose to cancer are familial adenomatous polyposis syndrome, Gardner syndrome, hereditary non-polyposis colorectal cancer, or Lynch syndrome. How the tumor can spread? The tumor is limited to the bowel for considerable time, 6 months for each. It spread around the intestinal wall, so there's a circular spread and usually causes intestinal obstruction before it invades adjacent structure. So the invasion first into the bowel wall and then go outside the bowel wall. So it takes about 6 months for every quarter of the bowel wall. The ulcerative type most commonly invades locally and an internal fistula may result, for example, into the bladder. Means that if after involving all the lumen, it invades to outside the surrounding structures, may invade into the bladder, may invade into the other organs in the abdominal cavity. Also may be local perforation with abscess formation and the external fecal fistula. We have epicolic N1, paracolic and intermediate lymph node is N2, and central colic lymph node is N3. Blood spread, this accounts for a larger proportion, 30 to 40% of late deaths. Metastases are carried first to the liver via the portal system. So we have the spread firstly to the liver via the portal system. We have 5 types of carcinoma of the colon. The right colon in the cecum, or the ascending colon, the transverse colon, and descending colon, sigmoid, and the rectum. So 5 segments of the colon in order to understand what the treatment and what the manifestation of each of these groups. Distribution of colorectal cancer by the sites: in the right colon, about 20%, transverse colon 5%, and descending colon is 7%, 7%, sigmoid colon 21%, and rectum 38%, and the anus 2%. This is the distribution of the colorectal cancer by the sites. First is the right colon in 20% and transverse colon 5.5 and left colon is 7%, sigmoid colon 21 and rectum 38%, and finally the anus 2%. Classification of colorectal polyps. Types of polyps: either neoplastic polyps or hamartomatous polyp and inflammatory polyp and metaplastic polyp. Neoplastic polyps either adenomas, tubular adenoma, or tubulovillus or villus adenomas. All are pre-malignant. Hamartomas, juvenile polyposis, and Pittsjover, they are not turned to malignant. Inflammatory polyps, ulcerative colitis and bilharzia polyp, and metaplasia, metaplastic polyps. So we have to know what are the types of colorectal polyps. We have 4 common macroscopic varieties of carcinoma, either annular type or tubular type and ulcerative type and cauliflower mass. So we have, this is the naked eye examination of the colorectal carcinoma is annular type, tubular type, cauliflower mass, and ulcerative type. What are the Duke's classification? Duke's classify the colorectal carcinoma into stage A, B, and C. A, it invades the wall, not get outside the wall, and the 5-year survival is 90%. Duke's B invades the wall and get outside the wall. This is the survival 60%. Duke's C with distant lymph node. So this Duke's A, B, and C. Clinico-pathological staging of colorectal cancer. Duke's staging: A, not breaching muscularis propria, B, breaching muscularis propria, C, invading lymph node, D, with distant metastasis. 5-year survival 90%, 65, and 35%. What are the presentation of the colorectal cancer? Right side differ from the left side. Right side comes with anemia, athenia, and anorexia, or mass, diarrhea, appendicitis-like symptoms, and small bowel obstruction. So on the right side we have anemia, 3 A's, anemia, asthenia, and anorexia, mass, diarrhea, appendicitis-like symptoms, and small bowel obstruction. On the left side, change in bowel habit means that progressive constipation means that the diameter or the caliber of the stool is small, and colic abdominal pain, progressive constipation, and blood in the stool. Non-specific abdominal pains in 50%. Rectum bleeding, sense of incomplete evacuation, means that the patient feels that there is something in his rectum. Normally, rectum is empty and just a passage of the fecal matter. But when there is a mass in the rectum, the patient feels that something in his rectum and he wants to defecate it. So he have almost always sense of incomplete defecation. Alteration in the bowel habit, tenesmus, spurious diarrhea, and pain. So what are the symptoms of right side? Is anemia, athenia, and anorexia, 3 A's, and left side progressive constipation and change in the bowel habit, and the rectum is the sense of incomplete evacuation, spurious diarrhea, tenesmus, pain, bleeding, mucus, and alteration in the bowel habit. Carcinoma of the right colon, 3 A's, anemia, athenia, and anorexia, mass in the right iliac fossa. Once more, carcinoma of the right colon, progressive intestinal obstruction, progressive constipation, pain, and distension. Attack of diarrhea may follow constipation. Acute intestinal obstruction, no mass is felt. If mass is felt, it is fecal impaction above the tumor. If there is a mass, there is fecal impaction above the tumor. Carcinoma of the rectum, bleeding by rectum, spurious diarrhea, sense of incomplete evacuation, and pain, extra-rectal spread. Blood test, complete blood count, liver enzymes, tumor marker, and this is tumor markers, carcinoma embryonic antigen, not a diagnostic, but we do it in order to take a baseline in order to know the response of the treatment. If this is high and will decrease after the treatment, so the treatment is accurate. And how we can follow up the patient if it is high. So the tumor marker, not a diagnostic. Liver enzyme is not a diagnostic. Complete blood count for anemia because it causes anemia and athenia and anorexia. And the colonoscopy, and the value of colonoscope to get a biopsy and to do a resection according to this biopsy. Imaging, either by CT or barium enema, and endorectal ultrasound and MRI. MRI is used for pelvic lesions and CT for the abdominal lesions. This is a barium enema showing the carcinoma here, and the characteristics here is what we call it apple core appearance, irregularity in the mucosa, narrowing of the lumen, and this one, irregularity in the mucosa and narrowing of the lumen. And this is in the sigmoid colon here, narrowing of the lumen and irregularities in the mucosa. This is long segment of tubular lesion here in the rectosigmoid area with irregularities of the mucosa. This is apple core appearance, very long segment tubular carcinoma. Another one of annular carcinoma in the rectosigmoid area. This is with irregularities of the mucosa, narrowing of the lumen with apple core appearance. Another one of cancer rectum here, but it is tubular type, a long segment. And this is manifestation of intestinal obstruction if there is complete occlusion by the cancer sigmoid. Cancer spread, direct spread, either longitudinal in the wall, or transverse, or radial, or retroperitoneal, or intraperitoneal. This is the direct spread. Lymphatic spread to the epicolic, paracolic, and intermediate and central lymph nodes, or para-aortic lymph nodes. Blood-borne spread, and this is go to the liver. First station is the liver metastasis. Liver in 50% and lung in 10%. Transcoelomic spread. Transcoelomic spread means that some cells becomes free in the peritoneal cavity to be lodged in another part, maybe in the jejunum, maybe in the ileum, maybe in the peritoneal nodules, or maybe in the ovaries, forming a Krickenberg tumor. The treatment is first surgery, radiotherapy, chemotherapy, and target therapy. Bulobectomy and local excision if this is small tumors and carcinoma in situ and very small one, so we have to do a just localized resection. Colectomy, either right or left hemicolectomy, or partial colectomy, or segmental resection. Nearby lymph nodes are removed as well. Anastomosis, and then making anastomosis between the iliotransverse anastomosis in the two sides. Why in two sides? Because the lumen of the colon is wider and the lumen of the ileum is narrow. So we can make a small opening according to the size of the ileum and making the anastomosis more or less visible. So we have to make what we call it right hemicolectomy with iliotransverse in two sides. Carcinoma of the transverse colon, we have to resect the hepatic flexure, splenic flexure, transverse colon, and the upper 1/3 of ascending colon and upper 1/3 of the transverse of the descending colon and making end-to-end anastomosis. Sometimes we may make extended right hemicolectomy, removing the right colon, transverse colon, and the upper 1/3 of the descending colon with splenic flexure, and making anastomosis in between the ileum and descending colon. So, in the transverse colon, we may do just transverse colectomy or extended right hemicolectomy with end-to-end anastomosis. Of course, the lymph node should be removed. In carcinoma of the left colon, we have to remove the lateral 1/3 or the left 1/3 of the transverse colon, splenic flexure, and descending colon, and most of the sigmoid colon, part of the sigmoid colon, and making end-to-end anastomosis. Up till now, there is no ileostomy or colostomy. And carcinoma of the sigmoid colon, we make sigmoid resection, of course, with the draining lymph node and end-to-end anastomosis. Also, there is no ileostomy or colostomy. Lastly, we have carcinoma of the rectum. We divide the carcinoma of the rectum into three thirds. The upper 2/3 by anterior resection, the lower 1/3 by abdominoperineal resection. The upper 2/3 with anterior resection, we're removing the sigmoid and the rectum and making coloanal anastomosis end-to-end, colorectal anastomosis end-to-end. Or abdominoperineal resection, that's removing the rectum, the anus, the rectum, and sigmoid colon, and making terminal pelvic colostomy. So, surgery of the rectal cancer, polypectomy and local excision if it is very early stages, low anterior section, proctectomy with coloanal anastomosis, or abdominoperineal resection or pelvic exenteration, means that if extended to the rectum, if extended outside the rectum to the vagina or to the uterus, we have to remove the posterior pelvic exenteration. If invading the bladder, we have to remove part of the bladder with it. So we may have pelvic exenteration and or diverting colostomy. Radiotherapy in the management of the rectal cancer. Preoperative radiotherapy, 30 GI, 57% relative reduction of local failure. Post-operative radiotherapy also have a 33%. So we are now using neoadjuvant therapy. Neoadjuvant means preoperative radiotherapy. And this is how we make the anastomosis down in the rectum, in the anal canal, in the narrow pelvis, especially in males. Now we have to look for if there is an intestinal obstruction due to cancer of the colon, and with a competent ileocecal valve, so we have what we call it closed loop syndrome. Carcinoma structure at the hepatic loop fracture, so there is a closed loop syndrome, may make the patient to be in obstruction. Now we have to go what we will do with malignant intestinal obstruction. Malignant intestinal obstruction, here the malignant lesion, we find here the malignant lesion. How we can deal with a patient with malignant structures? If a patient may have abdominal pain, vomiting, the 4 cardinal signs of the intestinal obstruction is pain, vomiting, abdominal distension, and absolute constipation. How we can treatment of the intestinal obstruction? Either one-stage procedure, two-stage procedure, and three-stage procedure. One-stage procedures means that if the patient are in the hospital and in the waiting list for treatment of the cancer of the colon, and then he develops while he in the hospital intestinal obstruction. So we can do an emergent colectomy with with direct anastomosis. So this is one stage procedure. Should be done by senior doctor, should not be done in the weekend. So this is one stage procedure. The patient is healthy, the patient is well prepared for the colonic resection. The two-stage procedures means that the patient is generally well and go in and do a resection and making just either anastomosis with covering ileostomy, or this is number one, anastomosis with covering and ileostomy. Number two, Ball Mikul's technique. Two ends are got out of the abdomen and making one colostomy and the other is mucus fistula. Or one colostomy and closing the distal stump and what we call it Hartmann procedure. So we have one stage procedure, which means that resection and anastomosis in one stage and the patient to go home. But two-stage procedure is first procedure is resection of the tumor and making an either ileostomy or colostomy. Ileostomy means that making anastomosis and then covering ileostomy. But two-stage procedure, colostomy just outside the abdomen, both ends of the colon, what we call it Ball Mikul's technique. Or one outside and the other is closed inside the pelvis, is called what we call it Hartmann procedure. Or three-stage procedure. Three-stage procedure, this is done in patient unfit for surgery, dehydrated, emaciated, everything is abnormal. So we just go and do right transverse colostomy or ileostomy until the patient is quite good, and then go in and making resection after 1 week or so, and then go in after 3 months and closing this colostomy. So one stage procedure, we end our procedures in one step, resection and anastomosis. Two-stage procedures, either done by resection and colostomy or ileostomy. And then after 3 months or so, we have to do closure of this colostomy or ileostomy. Three-stage procedure. First stage is colostomy, second stage is resection, third stage is closure of this colostomy. What we do with hepatic metastasis? Patient with up to 3 liver metastases confined to one lobe of the liver may be offered hepatic resection. Multiple painful hepatic metastases can be palliated by cytotoxic drugs, cryosurgery, laser therapy, and not by resection, or hepatic embolization, or what we waves and this microwave and these things. So patient with 2 or 3 liver metastases confined to one lobe of the liver may be offered hepatic resection. Hemoperfurin test and immunological test. The second, flexible sigmoidoscope every 5 years, total colonoscope every